Hi, I'm Dr. Elliot Brinton. I'm president of the Utah Lipid Center in Salt Lake City, past president of the American Board of Clinical Lipidology. It is my pleasure and privilege to present on behalf of the National Triglyceride Alliance a very interesting topic, chylomicronemia and acute pancreatitis. So please join me in a discussion. We have some learning objectives. We're going to review the relationship between severe hypertriglyceridemia, chylomicronemia, which is even higher, and the sharply increased risk of acute pancreatitis. We're going to talk about the presentation and pathophysiology of chylomicronemia. We're going to talk about a shift in terminology. We've been focused on FCS versus MCS. We now have some new terms we're going to talk about. We're going to talk about also diet, lifestyle, medications, kind of standard meds, but there's an exciting new class of medications in this field. We're going to cover that at the end. So we've got a lot of really fun things to talk about. So how does chylomicronemia present? It may well present with eruptive xanthomas. And these are a big rash of all these little bumps. They're kind of yellow in the middle, red around the outside, and they're rounded. They're not rough. They don't itch. They don't hurt. They're just there, and they kind of come and go as the triglyceride levels go higher or lower. And of course, this would be associated with creamy appearing blood, like a cream of tomato soup, but also the serum or the plasma is especially creamy. So this is how it often presents to us, although oftentimes we only get this physical finding by history, because it's come and gone right before we could see the patient. So what does this have to do with the risk of acute pancreatitis? Here you see some data. With the triglyceride below 150, the risk is rather low. It's mainly just alcohol and gallstones. Once you go above 150, maybe a little bit of an increase, but notice how much it goes up above 500. Now you're going to say, wait a minute, a triglyceride of 600, that's not going to cause pancreatitis. That's something else. It is, except if your fasting triglyceride is 600. Tell me how much of the time you're spending above 880 or above 2000. A lot, because it's those high baseline triglycerides that are predisposing to chylomicronemic excursions where you can and will get pancreatitis. Now, one little reminder, it's not just acute pancreatitis. This study shows dramatically how the risk of coronary heart disease can be associated with the same situation. Triglycerides above 500, increased risk of coronary heart disease. Now we're going to set that on the shelf. We're not going to focus on that, but just remember that these chylomicronemic patients are at risk for coronary heart disease and stroke as well. Now back to the question of chylomicronemia. Here we have acute pancreatitis on the left, chronic pancreatitis on the right. And again, we've got triglycerides, but now we're taking a little more granular look at it. Let's look at what happens with triglycerides above 500. To the right of that line, you see a rather steep upslope in acute pancreatitis and chronic pancreatitis, which is usually about half as prevalent, or the incidence is half of what it is for acute pancreatitis. Let's go above 1,000, even a steeper upslope. Let's go above 2,000. What's going to happen? Again, a steeper upslope. So there's a logarithmic relationship between triglyceride levels and risk of acute and chronic pancreatitis. Let's dive just a little bit deeper. We're going to look at the difference between 880 and 1,000, those top two bars. There's a little bit of a further increment, and then if you go above 2,000 or 5,000, it goes up even further. So dramatic increases. These episodes of acute pancreatitis that are related to chylomicronemia tend to be more severe than they are if it's alcohol or gallstones. The duration of the hospitalization is longer. The complications tend to be more severe, maybe a slightly higher risk of mortality. It's just really a bad situation to have acute pancreatitis due to chylomicronemia. It's really a terrible thing. And how is it that these two are related? Why do chylomicrons cause pancreatitis? Well, the pancreas, most of its mass is actually pancreatic lipase, intended for use in the intestine to lipolyze our dietary fat. Okay. But what if you've got a lot of chylomicrons in the microcirculation going past the pancreas? Will there be a little bit of leak of pancreatic lipase into the circulation? Yes. If there's enough of a leak, that leak will catalyze the lipolysis of the triglycerides in the circulation, producing free fatty acids Those free fatty acids are going to be pro-inflammatory. They're going to poke holes in the pancreatic acinar cells and cause more leakage of pancreatic lipase. And pretty soon you have a vicious cycle, a self-feeding cycle, where lipase leaks out, generates free fatty acids, generates more lipase leak. That's what we think is the pathophysiology of acute pancreatitis in severe chylomicronemia. So, what are the challenges that these patients face? Well, you can imagine one of them is it's very hard to make the diagnosis. Typically, a patient will see 5 or more providers before they actually get the diagnosis, oh, you've got chylomicronemia. It takes years and many visits. The docs are maybe not so empathetic. You show up at the ER, doubled over in pain. Oh, you're a drug seeker. No, you really do have pancreatitis, and maybe they're not doing the testing to show that it's true. You have to follow a very strict low-fat diet. Is that fun? No. Can't eat at restaurants, can't eat at fast food places, can't eat at your friends' parties, can't eat at family reunions. You can't eat the most tasty foods, and if you violate that, abdominal pain. What about alcohol? Just a little bit of alcohol, even a drink or two, can cause abdominal pain. So now you can't drink. You may have frequent, if not constant, abdominal pain. It's hard to move, it's hard to think. You may be bedbound. You can tough it out at home instead of going to the hospital, but then you're in pain and you're just toughing it out at home. You've got unpredictable onset of pain. It can come at the wrong time. It's hard to keep a job. The fear of the pain can be as debilitating as the pain itself. And it's not just abdominal pain and pancreatitis. You can have neurological problems. You can have brain fog, trouble thinking, poor judgment. You can have peripheral neuropathy that can be painful or involving numbness. There's a long list of bad things that happen in chylomicronemia. So what's the pathophysiology of how we get to severe hypertriglyceridemia or all the way to chylomicronemia? Well, let's take a look at it. We've got the liver upper left. We've got the intestine lower left. So upper left, lower left, we're producing VLDL in the liver. That's 24/7. We're producing chylomicrons episodically as we absorb fat from our diet. So those two triglyceride-rich lipoproteins meet up with lipoprotein lipase. Its job is to lipolyze the triglycerides. So the fatty acids go various places, and they tend not to cause harm because we're not generating these too fast. So the chylomicrons become chylomicron remnants, VLDL remnants very quickly, but not catastrophically. And then we produce things like LDL, and then the LDL hopefully is taken up by the liver, but what if it's not? Well, let's take a look at what LDL and the remnants can do. They can grow atherosclerosis. Ouch. So that relationship I showed you in passing is a causal one in which these triglyceride-rich lipoproteins, as they become remnants, including LDL, they're atherogenic. That's not good. So we've got this atherogenic problem overlaid on top of what I've described already in terms of acute pancreatitis. apoC-III is a good guy. It helps enhance the activity of lipoprotein lipase. We don't do this much clinically, but it's there in the background. So what else? Well, if these remnants are not cleared by the liver, then they're atherogenic. Hopefully they can be cleared, and the clearance can be enhanced by some of the factors I'm going to describe. Now, apoC-III is a bad guy. He is inhibiting all these steps, notably lipoprotein lipase, but lots of other steps, including hepatic uptake of LDL and its remnants. So apoC-III is a bad guy. If we can block him, we can unstick a lot of things that are stuck and causing trouble. So apoC-III inhibition is very promising. What about ANGPTL3 and ANGPTL4, those guys in the middle there? Those are other factors that also inhibit lipoprotein lipase. So maybe we want to inhibit them. Well, that's a lecture for another day. But back to the story of lipoprotein lipase. What reduces lipoprotein lipase activity? The bad things are loss of function of LPL itself, or its supporting Cas, the other enzymes and proteins that support it, help it. Loss of apoC-V, gain of function of apoC-III, that actually happens, believe it or not. And what will help us? What will increase our LPL activity? Gain of function, ANGPTL4 loss of function, maybe ANGPTL3 for that matter, apoC-III loss of function, and other factors we're going to talk about in just a minute. So that's kind of our basic pathophysiology. Now let's look at triglyceride levels. As you see at the bottom of this thing, it's called a violin plot. The vast majority of people in the US will have triglycerides under 150. 150 to 500 becomes much narrower. 500 to 1,000, much narrower still, and above 1,000 or above 880, chylomicronemia, much narrower still. So you've got this distribution very heavily skewed, and you've got chylomicronemia at the very peak. So now the question is, what is this? Is this familial chylomicronemia syndrome? That's a autosomal recessive biallelic disease, or is it multifactorial? Well, a lot of time and effort has been spent over many decades trying to sort these out and figure out which is which, but it's hard to know. It's really tough to know which it is. And so we can do genotyping, but that's got its limitations. It's expensive. Patients may not like it, limited access, false negatives. We can do clinical scoring systems. There are two of these. They're very good scoring systems. One is from Europe, very nice scoring system here. One is from North America. And what they're designed to do is to help us by phenotype figure out if it's true, pure genetic FCS or the more broad multifactorial chylomicronemia syndrome. Okay, so that's helpful, right? Except the prevalence of MCS is nearly 1,000 times more than FCS. Meaning, if you're talking about the severe chylomicronemia, there are actually 50 to 100 times more folks that are there because of MCS than because of FCS. So we're looking for a needle in the haystack, which is very tedious, very hard to do. Now, what about pancreatitis? Well, above this line is acute pancreatitis. You see FCS on the left, MCS on the right. Looks like there may be more MCS causing pancreatitis, but realize that that circle there for MCS is 1,000 times bigger than FCS. So in fact, the vast majority of acute pancreatitis episodes are in patients with MCS versus FCS. So the question is, do we really want to spend a lot of time and effort trying to find this needle in the haystack, this pure genotypic FCS, and then putting everything else in one basket? And I say no. Let's abandon our quest of FCS versus MCS. Let's take a different approach here. So what are we going to do? Let's take a fourfold approach. These are all clinically actionable. We've got the genetic FCS. We've got people that look for all the world like FCS, but you cannot prove it by genotype. Clinical FCS. What about folks that have persistent chylomicronemia, meaning more than half of their fasting levels are in the 880 plus range, but they didn't start as a kid. They don't have lots of triglycerides in the 5,000 range. So they're not really FCS, they're not really MCS, but they have persistent chylomicronemia that you can't get rid of readily by just treating secondary factors. And so you're left with persistent chylomicronemia. And then what? Well, have they had prior acute pancreatitis? Do they have pancreatitis or presentation of chylomicronemia as a kid? There are various factors here that are alarm features, meaning higher risk of acute pancreatitis. Well, what if they don't have those? Are they still at risk for pancreatitis? The answer is yes. If you're in chylomicronemic range, for reasons we discussed earlier, you can always get acute pancreatitis, and it can be your first. So you don't have to have a prior one to be at risk. So we've got 4 categories now. And the question is, well, so how are we going to approach this? Does this help us approach the treatment of chylomicronemia and prevention of acute pancreatitis? And the answer is yes. So what we're going to do is we're going to start with secondary factors. We're going to start with diet, a very low-fat diet, little or no alcohol. Sugar and fiber, less sugar, more fiber, not so helpful, but it's on the list. Regular exercise, we're burning triglycerides and free fatty acids. We're going to try to control, if not reduce, central obesity, insulin resistance, metabolic syndrome. If we already have diabetes, we're going to try to control glycemia because hyperglycemia impairs LPL activity, as does insulin resistance. Of course, hypothyroidism needs to be diagnosed and treated. We've got to watch for triglyceride-raising meds, especially oral estrogens, glucocorticoids, tamoxifen, isotretinoin. And then we've got other situations. Pregnancy, of course, that's a temporary thing, but that can cause chylomicronemia, CKD, nephrotic syndrome, viral diseases, various types of malignancies, anything that involves systemic inflammation, all sorts of factors. These are not very common, but we need to think, is there something else going on, some important disease in this patient that may be actually causing the chylomicronemia, and it's not just a primary problem. So primary treatment is going to be fenofibrate, excellent response in most cases except the pure FCS patients. Statins work okay, they're not as good, but remember they're going to reduce the risk of cardiovascular disease, that's great. And then prescription omega-3s. Now, why not dietary supplement? Those are cheap. The dietary supplements have a lot of saturated fat and they're heavily oxidized. And oxidized omega-3s don't work. So please stick to prescription omega-3s if you're going to add these to the list. And I think they're useful. They can be helpful in terms of managing chylomicronemia. In fact, I have a quick rule of thumb. If somebody with all those things we discussed on the prior slide still have persistent chylomicronemia, I want to call it FCS. And the reason is we've got two new very exciting drugs that are for FCS. And if I need those drugs, I need to diagnose the patient as having FCS. So I want to use a clinical diagnosis or definition of FCS so that I can go ahead and use these anti-apoC-III drugs now rather than waiting for something that's maybe coming down the pike. So here's an expert statement looking at those four categories. So look at those boxes in that middle row: genetic FCS, clinical FCS, PC with alarm features, PC without alarm features. We talked about those. Now the treatment is the next box down. If you've got any one of those three, you want to intensify lifestyle, do multidisciplinary care, combination lipid-lowering therapy, but then also what you're willing to do here, I think, is your anti-apoC-III, the new drugs. So what about PC without alarm features? Well, they have less risk, but they still have risk. And once you go through all those hoops and maybe a few more, you're going to follow them a little bit longer and be a little more patient with your efforts to try to reduce persistent chylomicronemia without resorting to the anti-apoC-III. Notice that this expert statement says, hey, it's okay. You can go ahead and use the anti-apoC-IIIs here if all else fails. So this is my definition of FCS. If all else fails, you can turn to those apoC-III drugs. So let's talk about these drugs. How do they work? Well, they block apoC-III production, but exactly how does that happen? And the first question is, can we take a little refresher on what apoC-III does? Why is it so useful to block apoC-III? Remember all these little curves with a little inhibitor thing at the end? apoC-III is blocking what we need to have happen in our system to get rid of these triglyceride-rich lipoproteins, not to have them hang around and cause acute pancreatitis. So blocking apoC-III is very, very smart. So how do we do it? Well, we've got olezarsen, which is an antisense oligonucleotide. It gets into the liver where the LPL is, where apoC-III is made, sorry. It blocks the production of apoC-III through this mRNA function that you see in the slide. What about plozasiran? Well, it's got slightly different mechanism, siRNA. It goes into the hepatocyte that's making apoC-III, and it blocks it by means of parking at a little thing called the RISC. So it lasts a little bit longer. The action is more longer lasting, but it's the same mechanism at its heart. So similar mechanism. Let's see how these drugs work. So these drugs are both now FDA approved. And the question, how do they get approved? Well, the pivotal study for olezarsen or Tryngolza was the BALANCE trial. Everybody was genotypic positive FCS. Most of them had had acute pancreatitis, baseline triglycerides mid-2000s on optimal treatment. Triglyceride reduction, very, very good for somebody with LPL deficiency, right? Because we thought it was mainly going to be disinhibiting LPL by blocking apoC-III. No, there are all these other LPL independent pathways that are enhanced and increased with apoC-III inhibition. So acute pancreatitis goes down by 88%. Wow, a huge win. A couple of potential problems listed there, but nothing really too much of a problem, because remember, we're treating this devastating illness. You dose it every 4 weeks with an auto pen, and the access is good. Plozasiran, brand name Redemplo, the new kid on the block, just FDA approved. Palisade was its trial. The FDA asked for them to include some non-genotypic FCS, so they did. History of acute pancreatitis was almost everybody. Baseline triglycerides about the same. Reduction in triglycerides probably a little bit better, but the reduction in acute pancreatitis is very comparable. So we're getting a dramatic reduction in the vast majority of acute pancreatitis episodes with either one of these drugs. A few potential issues you see listed hyperglycemia here, low platelets on the other side, various things. It's every 3 months with a syringe. Access, we think, is going to be excellent. Okay, so we've got 2 great drugs. So now what? Well, the now what is, let's go a little farther. Let's not just be stuck on FCS or something that looks a lot like FCS. Let's go beyond to SHTG, triglycerides above 500, maybe enriched with folks with modest or moderate chylomicronemia. So now we have 2 trials with olezarsen, CORE and CORE2. More than 1,000 patients, not quite half, but a lot of them with triglycerides over 880, and not a lot of them with acute pancreatitis, 15 to 25%, but still reasonable prior history of acute pancreatitis. And most of them are on a fibrate, most are on a statin, a lot of them are on omega-3. Let's see what happens to triglycerides and acute pancreatitis in this broader population. So these are these 2 trials. We're looking at them separately, but also together. And here we first of all have the triglyceride reduction. And you see it's pretty dramatic in both trials. Slightly better with a higher dose of olezarsen, but fairly comparable triglyceride lowering with either dose, 50 to 70%, depending on the trial and placebo correction. So very nice drop in triglycerides. And then the question is, well, do we get people's triglycerides below 500? The answer is yes. 86% get down there versus 35% with placebo. And that's a good threshold to go. We also can cut in half the number of patients who remain above 880. So huge drop in the severe hypertriglyceridemia or the chylomicronemia with this drug at these 2 doses. Very nice, very encouraging. So what about acute pancreatitis? That's, of course, why we're treating triglycerides in these patients. And there's an 85% drop in pancreatitis, very comparable to that in the smaller trial in the more severe patients. Very, very positive, very encouraging. I love this. Number needed to treat 20. That's great. If you focus just on the folks with triglycerides over 880 at baseline and a prior history of acute pancreatitis, that much smaller group has the vast majority of the pancreatitis episodes, a similar percent reduction, but now the number needed to treat is only 4. This is getting very exciting, I think, in terms of something that's clinically actionable. And of course, we don't have this on label yet. It's just been done. It's being submitted to the FDA as we speak. But I love the direction that we're headed here. So we've got olezarsen with the CORE trials. There's some caveats here. The most important one to me is that the vast majority of the cases of pancreatitis, you had to have both a high triglyceride over 880 and a history of acute pancreatitis, but it still may be worth using in those patients who are somewhat lower risk. Plozasiran has 2 very comparable trials, Shasta 3 and 4. They're in process. Results will be out middle of 2026. My prediction, I think the FDA will approve both of these drugs for this broader indication. I'm very excited about it. Details are a little murky yet because, of course, we don't have any idea what the FDA is going to think. In fact, they've got to spend a lot of time. They'll spend many months on this. But I think we're headed into very, very favorable territory where we've got a lot of stuff in the background. We've got these new drugs that are very exciting for the very, very highest levels of chylomicronemia. And now maybe we can go down into persistent chylomicronemia and maybe even down into severe hypertriglyceridemia in that 500 to 880 range. Very, very exciting times. We've got a lot of tools, a lot of fun. It used to be a terrible thing to try to treat chylomicronemia because it was so hard. Now we've got more tools and more success at treating this terrible disease and helping the patients avoid pancreatitis and be able to live normal lives. So thank you very much for your attention. I hope you've enjoyed our quick little tour.